All right, well, sorry about that. I am having technical difficulties here. Okay. All right, welcome everybody. Thank you so much for joining us today. I know you're all busy people and we appreciate your spending the time with us. I am Judge Laura Mack. I am the president of Families Against Narcotics, Northwest Wayne chapter. Our organization exists because of the opioid epidemic that we're currently experiencing, and that's getting worse. Our topic today of harm reduction is critically important. As you know, as you probably know, overdose deaths topped over 100,000 last year, and it seems to be getting worse every year. So these programs save lives, and so we're very happy to bring this to you, this exciting program that's happening in New York. Okay, so I'm going to start just a PowerPoint that just quickly goes through what we're all about. And tells you about upcoming events, and then we will turn it over to Lauren, who will introduce our speakers from OnPoint New York City, and we'll get started. So I am going to share my screen. Hopefully this works. Do you all see that?
Yes.
Okay, great. Okay, super. All right. As you know, this is Families Against Narcotics, a grassroots organization.
Did we lose her?
It looks like we just lost Judge Mack.
I think we did.
I wonder how that happened.
You don't know? I wonder if Alfred, did you just jump on? No. Well,
Well, hold on one second. I think that I have the PowerPoint slide, so maybe I'll pick it up. Yeah.
Okay.
Although I did not put the ones together so that she had in front of them. But we will move forward with this.
all right.
All right.
I still see a square that says Judge Laura Mack, so.
Alfred
Well-
was on that square, so.
And it says that the host disabled sharing, so I can't share.
Okay.
Let's just talk about it then.
Let's see if we, yeah, I'm not sure what happened to her.
Well, we apologize for these technical difficulties for sure.
You know what? I'll tell you what, I guess she had some introductory remarks to make, but I think what we're going to do is maybe jump straight into our presentation. And then Laura can pick up with remarks when we conclude. Does that sound like a good plan? All right. So I have a few things I was planning to say. My name is Lauren Rousseau. I am one of the board members at Northwest Wayne Families Against Narcotics. And formerly president of the chapter for a number of years. And so good evening, everyone. I am very privileged to introduce our speakers for this evening, Kaylin C. and Pia Marcus. Before I introduce them, I'm going to say just a few words about the concept of harm reduction, sort of picking up where Judge Mack left off. And I think I'll include with that, I'm going to tell you a little bit about my background that gives maybe some depth to the remarks I'm about to make. So I started doing work. I started doing work in the addiction and recovery advocacy area in late 2012. In early 2015, I gave my first presentation on the opioid epidemic and drug overdose deaths in the country. I took a look at that presentation and some other presentations that I gave up to the present time and at the numbers that I cited in it. In 2015, I was talking about the health crisis that we were experiencing at that time as a country, because nearly 44,000 people had died from a drug overdose in 2013, which at that time seemed particularly shocking. It meant that every day in the country, 120 people had died from a drug overdose. I gave another presentation in 2016, again citing overdose death numbers, this time from the prior year, 2015. At that point, 52,000 people had died of a drug overdose. In 2016, the number exceeded 64,000. In 2017, the number hit 70,000 for the first time. And I recall people that I had been working with in the addiction treatment and recovery area being pretty shocked that we had gotten to that number, that we'd hit that number. And then, as Judge Mack said earlier, last year, 2021, more than 107,000 people died from a drug overdose in this country. According to the CDC, over 1 million people have lost their lives in this country as a result of drug overdose since 2001. So many of us, for quite a few years, have been working so hard to try to make a difference in this area, but the numbers just keep going up. Whatever we're doing, it seems like it's not working. I remember back in 2012, when I began doing this work, the concept of harm reduction was viewed fairly negatively by many people. A lot of people thought it encouraged continued drug use instead of supported recovery. Needle exchange programs had been around for a while, but they were almost seemed like sort of hush-hush in the closet. Even opioid medications like methadone and buprenorphine were considered harmful and enabling in many circles, including in the recovery community and in a lot of treatment organizations. But as the overdose numbers just keep going up, people have begun to focus more attention on trying to keep people safe and saving lives. People have begun to recognize that a person can't recover if they're dead. State and local governments, community organizations, they've all worked hard to increase access to Narcan to reverse opioid overdoses. And laws have been passed to make it easier for lay people to obtain Narcan and also to administer it. Needle exchange programs have sort of come out of the closet, have become more accepted. Many community organizations are offering fentanyl testing strips at meetings and events. Just in the past couple of years, Families Against Narcotics has launched a program called Harmless, through which support teams meet people who use drugs where they're at to help connect them with essential resources that they need to stay safe, to stay healthy, and to stay alive. These resources include Narcan, sterile use supplies, syringes, Hep C and HIV testing, basic healthcare services, medication-assisted treatment, and more. Our speakers this evening are going to tell you about the next frontier in harm reduction. In December 2021, OnPoint NYC opened the first 2 officially sanctioned overdose prevention centers in the United States. At these centers, drug users can bring their drugs and use them under the watchful eyes of staff ready to intervene in the event of an overdose. Other community groups have tried to do this. They've tried to open centers like this in other parts of the country, but so far, they haven't been able to get them off the ground. Canada's had centers like this for quite a while. There's currently 37 centers in Canada. They're sometimes referred to as safe consumption sites. Our speakers this evening are going to share with us how their centers operate, their purpose and goals, how their organization was able to launch this program when others in other parts of the countries have been unable to do so. Kaylin C. is the Senior Director of Programs for the Washington Heights Corner Project and the New York Harm Reduction Educators, serving Washington Heights, East Harlem, and the Bronx in New York City. She was the program and development lead for the historic opening of these 2 sanctioned overdose prevention centers that I just mentioned. Before moving to New York in 2016, Kaylin worked in Vancouver, Canada, developing and operating innovative, award-winning drug user-focused programs. Her many years of working to improve the lives of people who use drugs has given her the opportunity to garner experience across multiple sectors, including housing and shelter for substance users, community-based detox and treatment, social enterprise, drug policy reform, advocacy, and safer consumption. Our other speaker, Pia Marcus, was born and raised in New York City and began to work in harm reduction in 2015. Prior to this work, Pia spent 3 years working in rural Rwanda and Uganda with grassroots sexual health and nutritional health programs. Pia returned to the United States in 2015 as a Global Health Corps Fellow in Washington, D.C., where she became an outreach case manager at a local syringe exchange. Pia joined New York Harm Reduction Educators in 2016 as an outreach case manager. She quickly rose in the ranks to field supervisor, then field manager, and then associate director of syringe access and outreach. In 2019, Pia was promoted to Director of Syringe Access and Outreach, and in 2020, she became Director of Syringe Access and Program Innovation. So I'm now going to turn the program over to our two speakers. After their presentation, there'll be an opportunity for Q&A. So Kaylin and Pia, take it away.
Thank you. Thank you so much for having us. Just to clarify, I'm Kaylin
And I'm Pia.
and this is
Hi.
Pia, and we're going to share a screen. I'm going to share my screen for a second, and we just have a couple slides to go through, and then we'll get into a deeper discussion. I don't think I can share my screen. Is there a way to enable that temporarily for us?
Yes, here, let's see. I should be able to do that. Okay, I don't know, Alfred, you may have to do that.
Check in right now.
Thanks, guys.
Okay, please try now.
Okay. Yes, there we go. Okay. All right. Can everybody see that?
Yes,
Okay, great.
Yes.
So I just really want to start by saying it's a real pleasure to be here. We're grateful for the opportunity to talk about this work for you, and I'm blown away by the open and the introduction and your remarks, Lauren. And then before we lost you temporarily, Judge Mack, but by your remarks as well. This is clearly a very compassionate and dedicated group of people, and we're really looking forward to this discussion. And really, frankly, Lauren, you did half my job for me. You talked about why now and why it's so critically important that we have this conversation together now. So we don't need to spend too much time on this, but I do just want to really bring us home to the people that we don't have with us today who can't participate in this discussion. And your website has the Lost Too Soon tab, which Pia and I went through today. And then Israel, he's the guy holding the cell phone in this photo. He's holding a photo of a 21-year-old participant who is a program participant of ours who died in the tent behind Izzy before the overdose consumption, the overdose prevention sites were opened. So I think we are really rooted in why now. And that's really thanks to Lauren for that introduction. Let me see here. You also talked as well about the body of evidence for safer consumption sites, so we won't spend hardly any time on this either. We all know that no one has ever passed away from an overdose in a safer consumption site in their 36 years of operation. We also know that there's a massive body of evidence evaluating these sites, peer-reviewed evidence published in very well-respected journals and other publications from around the world. But what was lacking was an American example. And Americans want American examples and they want American research. And we haven't had that up until this year. And we're really fortunate to now have the two sites operating in New York City. I want to go over some of the early data that's coming out of our sites, just so that you can sort of process how successful the sites have been in just 7 short months. We have, even this data is a little bit old, we have just under 1,500 people registered to both sites, 1,000 at our East Harlem site, and just over 400 at our Washington Heights site. And I apologize, you can probably hear my baby in the background. She's just about to go on a walk with dad, so just bear with us for a second. Our sites have been used over 27,000 times. Even this data is a little bit old. That's 27,000 instances where someone could have lost their life from consuming drugs. As we know, fentanyl has really adulterated the vast majority of the drug supply, and anyone who is opiate naive is at especially high risk, and certainly anyone who's using opiates is at high risk as well. So in East Harlem, again, you're seeing a slightly higher usage compared to the Washington Heights site, and we'll talk a little bit about why that is. Overdose interventions sitting at around 370 at the moment. What I find interesting about the overdose occurrence rates is, despite the lower enrollment at the Washington Heights program, and we'll talk about why there's a lower enrollment there, they account for the vast majority of the overdose occurrence. So again, we have 400-ish people overdosing a lot versus 1,000 individuals not really overdosing as much as the other program. Our overdose is broken into 3 different categories. One is an opiate or depressant involved overdose for which naloxone is used. and we microdose naloxone. Many of you are probably familiar with the nasal formulation, the 4 milligram nasal formulation. We don't use that in the overdose prevention sites. And if there are more questions about our particular style of overdose intervention, we can unpack that in the Q&A a little bit. But of those 370-ish overdoses, naloxone was only used 67 times. That does not mean that the other opiate or depressant involved overdoses weren't really grave in nature and wouldn't potentially have resulted in a fatality if we hadn't been there. It just means that the immediacy of the intervention, the immediacy of the response when you are there at onset totally changes the shape of the intervention and the tools that you can use to completely resolve it. So we are not triggering withdrawal, precipitated withdrawal in the folks that use our site. We're pulling off just enough of the opiate from the receptor to allow normal respiration. But we are not sort of going into overdrive with that naloxone. We're using oxygen therapy and other tools. The last category is the overamps, and those are essentially stimulant-involved overdoses. So that can be psychosis, delusions, hallucinations, shock presentations, seizures, stroke, any kind of cardiac event, or any other instance where someone is no longer able to regulate their behavior or their mental state. They're not rooted in present day and time, and they're not able to engage in rational thought and are thus a danger to themselves and possibly to folks around them. Of those 370 overdoses that we were talking about, I really just like to end this slide by saying we've only had to call the ambulance 5 times. And you can just, I know we've got public health people in this forum. You can do the math yourself on the downstream healthcare, emergency services, and law enforcement cost savings that this site has already yielded because of the efficacy and the high quality of service that we're offering in both overdose prevention centers. And then again, you know, we've got this comparison of stats here and really this analysis of the value of an American life with this slide that asks us to really consider if we lost 102, almost 103,000 American lives in every US military conflict since World War II. And we as a sort of a culture deem that an unconscionable and unacceptable loss of American life. And yet, as Lauren pointed out so eloquently in the opening, we've been losing nearly 100,000 Americans to overdose deaths in the United States for many years. Yet we don't seem to see this the action that we need to be seeing to resolve this. Since opening our sites, now shifting a little bit to community impact and public safety. Since our launch, both overdose prevention sites have diverted over 500,000 units of hazardous waste from New York City parks and public spaces. And I want to take that a little bit further to say that we have picked up the entire instance of use, the entire instance of consumption, and we have taken it out of the public sphere and put it somewhere safe, private, and dignified. We often say that we built these sites not only for the participants who we love very much, who rely on them, for an essential services that connects them to care and saves their life. We also built these sites for the community members in the 2 neighborhoods where we operate. These sites have a dual focus and they take care of 2 different sets of needs. And I think that's a really important thing to remember when we talk about safe consumption. So the Washington Heights model, when we saw the opportunity to squeak through the door, and it was a very, we can talk about this a little bit more, it was a very finite, time-bound, unique political moment that we made the most of. I won't say that we exploited, that we made the most of to get these sites up and running. We got a little bit greedy because we didn't know if this site or if this moment, another such moment, was going to present itself. So we opened 2 sites at the same time, and we strategically and intentionally opened 2 different models. We did that for a couple of reasons. One, we kind of wanted to make our program enticing from an evaluatory perspective for NIDA. If we could get a federal researcher to come on to evaluate the sites, we had a modicum of protection at the federal level. As soon as you have a federal researcher, you're now sort of in research pilot, that realm, and you're a little bit safer in terms of federal prosecution. So the Washington Heights location is our peer or consumer-led model. What that means is that the people working in the site either have very recent lived experience or are in active use while they're working in the site. They are highly trained, paid, salaried employees who have been with us for a long time, who are stable in their use or practicing maintenance use. The peer model is an excellent model. It's also been really heavily evaluated, and a lot has been written about the efficacy of the peer model. It's cost effective. It's cheaper to stand up. You can see some simple chairs and tables in the picture on the slide. The Washington Heights program is a much younger population. The average age of the participants there is 28, and they are predominantly a high volume injection population, speedballing, heroin, and cocaine. It's a high homelessness rate among the participants in Washington Heights. Many of them are encampment dwellers or otherwise street homeless or living rough with each other, rooftops, stairwells, that kind of thing. And as we mentioned earlier, there's a much higher overdose occurrence rate than in the East Harlem program, despite a lower registration number. And I just want to be a bit of a drug dork for a second here, a bit of a drug nerd. The half-life of heroin is between 5 and 6 hours. And the half-life, of course, is the duration that a person would feel the effects of a substance, both neurologically and in other systems within their body. The half-life of fentanyl is between 2 to 3 hours. The half-life of cocaine is between 45 minutes and an hour and a half. So a speedball injector could be potentially injecting between 18 and 20 times a day. And each of those injections would involve potentially multiple syringes. So this is, without a doubt, the highest risk population in terms of drug consumers in America today. In one day, there are potentially 18 to 20 instances where a speedballer with an adulterated drug supply could potentially lose their life. So these sites are really critically important, obviously, for this population. Our sites aren't open 24 hours yet. And in Washington Heights in particular, in the overnight hours, I'm really very sad to report that we have lost 4 participants who rely on the site during the day, who in the overnight hours overdosed, 2 in a train station and 2 in buildings right around the overdose prevention site. And one of those was one of our staff who overdosed when we weren't open in a building beside the overdose prevention center. The East Harlem model is the more traditional medical model. You can see in the photos what you would expect to see in terms of safer consumption, the classic stainless steel booths and big mirrors. This is a design build model, so it's a little bit more expensive in terms of resources. There are medical licensing considerations with the medical model that aren't present with the peer model, medical licenses for doctors, nurses, etc. Remembering, of course, that we don't have federal or state permission to operate these sites, so medical licensing is still a consideration for any clinician who may want to work in an overdose prevention site. The Harlem program is an older population with many veterans, and it's a high volume inhalation population. So yes, there is still injection, but Harlem has a dedicated smoking room, a communal smoking room, to accommodate the higher volume of need for inhalation services. Still a high rate of homelessness amongst the participants in East Harlem, though a significant percentage are housed. And there's a lower overdose occurrence rate compared to Washington Heights, despite the higher registration. And this is predominantly around age. The young pups are reckless. The older population has learned a couple lessons over time around safer drug use. And it's also the mode of administration. Smoking is less risky than injection. Oops. And then lastly, we're going to talk about this a lot. I just know that we are, but dispelling a few myths about safe consumption sites. They do not create drug users and they do not promote drug use. There isn't one sentence in 36 years of peer-reviewed scientific research that supports the notion that these sites create or promote drug use in any way. These are public health services meant to meet a very unique medical and healthcare need of a very specific population. So that's one of the myths that we're really eager to dispel. And we understand why people sort of hold that belief about these sites, but it doesn't actually bear out in the evidence. And it's definitely not true for our 2 sites in New York City. Of the sort of 1,500 or so registered users for both sites, in the high 90th percentile, even still 7 months in, are existing program participants for both programs. The East Harlem program is 35 years old, and the Washington Heights program is 17 years old. These are long-standing existing programs that have been working with people who use drugs for a long time. And even still now, we're continuing to enroll existing program participants. These aren't new drug users who are coming in from the boroughs or other parts of New York State. And then you can see just a few quick stats here around some of the benefits of standing up safe consumption spaces, and the evidence does support these. They do reduce the spread of HIV and hepatitis C. They absolutely reduce overdose death. They save money to the healthcare system. They reduce public disorder and improve public safety. They do not increase drug dealing. They are an important part of diversion with law enforcement. We are currently engaged in some low threshold diversion work with the precincts in both of the areas where we operate, both neighborhoods. And for the NYPD to come on and say, we want to partner with you, we want to make this work, is huge. And you've all heard about the NYPD. Believe us, when we were on the threshold of opening the sites, one of the last sort of question marks for us was, can we get the NYPD? And we have. They're a very committed partner. They want to make these sites succeed, and they're really grateful for the piece of policing work that we have taken off their plates. And law enforcement from other jurisdictions would support that assertion. This low-level sort of harassing policing of street entrenched people who use drugs is a waste of police resources, and they don't want to do it. And they're not effective in that realm. So the NYPD has said, yes, absolutely, we see the role that you play. Now, when they find street entrenched people who use drugs in the neighborhoods where we operate, they now bring them to our sites instead of engaging in these misdemeanor arrests and generating that just bulk of paperwork and some kind of system jam that often results. And then I think I'll close this out and we'll talk just a little bit. I'm going to stop my share about how we managed to pull this off, unless there are any other questions that have come up from the presentation.
I have seen a lot of comments in the chat, but I have not seen much in the way of questions so far. We're going to do our Q&A through chat when the time comes to do that.
Okay.
And I think that I've been seeing a lot of comments in the chat that are almost angrily supportive of what you're doing. and I'd kind of like to ask the people who are angrily supportive to calm down, because this is sort of something that is, you definitely have people on the other side who this is a really hard pill to swallow, who are kind of used to, a different mindset when it comes to illicit drug use. I think that many people are slowly coming around to the idea of harm reduction. And this is like one more sort of big step. So I feel like there's a lot of questions that, that need to be answered without people feeling like they can't ask them because certain other people have overly strong feelings on the subject. So I just want to throw that out there before we start our Q&A. And then let's see, I do see one question here in the chat. Is there information that's able to show how many people seek recovery after being involved in an overdose prevention site?
Yes, there is. It's very early days. So in any other sphere, you wouldn't ask for data that supports these kind of longer term outcomes at the 7-month mark. So we, just like any other sort of program that's being evaluated, we are also not able to produce data that supports, or that can point concretely to these longer term outcomes. However, we have some very early and very promising observations coming out of both sites. One of them is 80% of the existing overdose prevention center participants have been connected into further medical care, treatment, mental health care, HIV and Hep C care directly from the OPCs. What's so interesting about that, the reason why this makes me want to like hit my little confetti reaction button on the Zoom, is because go back to what we just mentioned, that many of these folks have been existing program participants for years. So what was it about interacting with the Overdose Prevention Center that made them ready to take this additional step? And it's 80% of them have engaged in care in a way they hadn't previously engaged in care with the agency, despite being deeply enmeshed with the programs and services that we offer. So that's one. The other thing that I want to make really clear, and this is going to sort of like probably ire a few folks. Believe me, we know how lucky we are being in New York City. New York City is the most progressive state in the country in terms of harm reduction policy, a political will around harm reduction, and funding, robust funding from city and state Department of Health for this work. So we're sort of in Mecca. It's sad to say this because we have so far to go, but we do get how lucky we are. One thing that is really important to note, and I'm a big believer of this, I've opened consumption sites and run consumption sites in Canada. I've toured most of the consumption sites and know the folks that are running sites in Europe, many of them. And we had an opportunity in New York to kind of build our dream site, although in a very truncated timeline. And I really firmly believe that co-location of the overdose prevention site with other programs and services in the American context is essential for its success. There is a criticism of overdose prevention sites, which I actually agree with. I'm going to regret saying this because this is being recorded, and I know this is going to come back to bite me in the butt, but detractors and critics of the site say, yeah, you guys are so proud that no one has ever died of an overdose in an overdose prevention center anywhere around the world in 36 years. What happens is you intervene in the overdose in the site, then you discharge them, the naloxone wears off and they die outside your sites, all over our communities. That doesn't happen if the consumption site is co-located within a larger program. So when Pia and I and our team are done working with someone in our overdose prevention site, we've intervened in whatever medical emergency has presented, or we've decided they cannot be discharged, we have to transfer care. We transfer care to another one of our teams who is really highly trained and is going to monitor that person. Our programs are dynamic enough so that when people kind of come to, they don't want to bounce. We have food, showers, laundry, groups, educational and job reentry opportunities, case management, clinical care, all kinds of programming, low barrier mental health care, all available on site, so that there isn't a need to bounce away from our program spaces following an instance of consumption and back out into the public sphere. This is really, really critical, especially for the American context where optics on the street are going to make or break the success of your site. So please, if you are considering kind of advancing this work in some way, please co-location, 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 critical. Backing up a little bit in terms of how we did this. There's a couple through lines in the safe consumption story globally. One of them is a transition of power. And we had this in New York. So this was true in Canada for Insight. This was true in Australia. This is true in Switzerland. This has been true in Norway and Germany as well. There's a transition in power that is often exploited by one of the parties in favor of this kind of intervention to kind of sneak it through during a moment of political chaos. And I'll just call it what it is. That's what happened in New York. So we had Como, who was, kind of dealing with these accusations. And there was chaos at a gubernatorial level. And was Hochul going to come in? Was he going to resign? Was he sexually assaulting women? Just a whole bunch of hubbub at a state level. And then we had an outgoing mayor who felt that he was a bit of a lame duck mayor and needed a legacy and wanted a legacy and felt that he could throw his political clout. Everybody knows that Como and de Blasio were not Romeo and Juliet. They fought bitterly. They almost disagreed just for the sake of disagreeing with each other. They really did not get along. They were not politically aligned. So de Blasio wanted nothing more than to push this intervention through that he felt Como had stymied for many years, while Como was getting like a dressing down in the background for these allegations. That's one piece. So I want to make clear, the moment that Sam, our executive director, Sam and I and Pia and the rest of our team decided as an agency we were going to take this risk, that day to the day the sites opened was about a month and a half. And that includes building the sites, 2 of them, writing the policies and procedures, trying to figure out if we were all going to get hauled off to Rikers, training the staff, everything, about a month and a half, including all of the political lobbying, the multi-level, the tiered risk assessment we did at a federal, state, and local level. Who is in power now, who's on their way out, who's coming in, who's soft on the issue, who's not, where are the feds? Really doing that risk assessment, because I want to make very, very clear, the body that took the risk to open these sites was us. It was not the health department, and it was not Mayor de Blasio. Mayor de Blasio was in power for 2 months of the operation of these consumption sites before he was safely out of office. It was a real push to get it done before he left. That was the window. We had to squeak through the moment before Hochul was appointed, where she could make a decision to stop the opening of the sites, and before de Blasio left office. I can answer other questions about that if they come forward. So what did we have that we could hang our hats on in terms of protection from prosecution to give sort of assuage our legal concerns about opening these 2 sites? We had a couple important federal precedents that we looked at, and I'll talk about those in a second. We had folks in the state that we thought would do some gatekeeping for us, i.e., not poking Hochul, not pushing her into a corner to get her to make a decision. We were reasonably assured she would leave us alone at a state level. And then we had the backing of the city. So we had a mayor from Mayor de Blasio at the time. We had a letter from him. And of course, the mayor oversees and directs the law enforcement agency for the city. So we were reasonably assured that the mayor would direct the NYPD to stand down. But we had nothing in writing from the NYPD, and we knew we weren't going to get anything in writing from the NYPD, but we didn't force the issue. If we had forced the issue and insisted in something in writing from the NYPD, we wouldn't have opened, because they can't give us that. It's federally illegal and it's not sanctioned by the state. So we really had to pick our battles in terms of what are we going to insist on having, and where can we just feel comfortable with a backroom conversation. And again, this is even as I'm talking about it, I'm like, man, what were we doing? This was, and how are we not all in jail? But of course, the NYPD didn't come for us and the feds didn't come for us. The 2 federal examples I'm talking about are, of course, Safe House in Philly, and Rhode Island. Rhode Island is the only state in America to authorize safe consumption services at a state level. And they were visited by the FBI multiple times and sort of harassed by the FBI in their early planning process, and kind of really given the message to cease and desist any planning around safer consumption. They were very early on in the process. They didn't have sites built, they didn't have policies and procedures written, they didn't have staff trained, and they were kind of having this involvement from the FBI. Safe House, we all know how that worked. They did receive a cease and desist letter from DOJ, and they were very early on in the process. Didn't have sites built, didn't have a location, no staff hired, etc. Here we were we built sites and intentionally leaked photos of the sites just high enough at DOJ, not too high. You got to find the sweet spot, not so high you're poking the bear and eliciting a response, but high enough you know it'll be taken higher. And we did the same thing with ONDCP. We did the same thing with our policies and procedures, got it into certain hands that we knew would quietly get it where it had to go to gauge reactions with enough time that we could change course if we thought it was really going to hit the fan. So multiple kind of strategic planting of seeds amongst various stakeholders across the country just to see if there was a reaction. And there wasn't. I see a lot of people just like, yeah, so that's those two pieces. One more thing that was in place that we had that really enabled us to do this in that very truncated timeline I mentioned. We had been operating unsanctioned consumption facilities for 6 years, and big ones. And we had, over the course of that 6 years, refined our skills and our capacity as an organization to do this work as close to flawlessly as you can. It's a big ask for staff to sit in witness of people consuming drugs day in and day out. There's trauma transference, there's all kinds of triggering. There's, I know at this group in particular, the loss, the deeply held feelings people have about drugs, people who use them, that loss of life. We had 6 years of working with our team to be ready for this moment. We also used the sites to we strategically outed ourselves at very strategic moments over those 6 years to specific stakeholders, including elected officials in both neighborhoods where we worked, kind of coming at it from the frame of, listen, you don't want people dying all over your jurisdiction. You don't want public drug use everywhere. You don't want syringes everywhere. You may not like this, but you need to see what we're doing because this is a part of the solution. And bringing them in and again, taking another big risk and saying, this is what it looks like. This doesn't exist in the public realm here, but it should. And you don't need to be afraid of this. Ask the questions you need to ask about this, but like, look at it. Let's be uncomfortable, but this is working. And what we want you to back us to do is to bring this out of the shadows and into the public realm. 6 years of this work, even showing the precincts in both areas, both neighborhoods where we operated, even bringing them in and saying, this is going to blow your mind, but this is what we're doing. This is the role we think it can play to improve your job. And this is, you know, we get that this is illegal. We get this, we get that, but let's have this discussion. Now, we didn't just willy-nilly just put up an open house sign and say, come on in, we're running unsanctioned consumption sites. It was finding those strategic moments. So a young person in overdoses and dies in Harlem and it makes the news. We have a moment. Let's get the political officials in. We're having a public summer comes. All the drug users are all over the neighborhood. There's syringe litter everywhere. There's syringes in the school. People are using in the school grounds. We have a moment. We can do a reframe here. So we're really good at finding opportunities where our back was against the wall to say, we can do better, but that requires you backing us. Instead of chasing us out of the neighborhood, you need to double down on us as an organization, get firmly in our corner and help us scale up this kind of work. I think I'll stop there for a second. Any questions?
Any questions, folks? I think I was writing stuff down as we were going. Did you have something, Judge Mack?
Yeah, I apologize first of all for earlier, and I will try to do the PowerPoint maybe once we're done with questions, just to run through upcoming events and things like that. It just disappeared on me. So my question is, you mentioned that these programs had been running in some form before you formally launched these 2 locations. Just clarify that for me, that there were safe consumption sites before.
Yeah, I can take that one.
Do you like this view?
Okay.
I like this view. I do like that.
Okay.
So the New York State Health Department, many years ago, 2016, thank you. 2016 came out with a regulation and an instruction for syringe service providers that stated that they needed to have a overdose intervention policy and procedure in place in the event of somebody using in a bathroom. So what the state was saying was, we know that when you give syringes in a program, people are going to use those syringes in a bathroom. This is happening all over the country in public restrooms. And so of course it's going to happen in the bathroom of a program that gives syringes. And as the state health department, we don't want anyone to die in the bathroom of a syringe service program. So you need a policy and procedure in place. Instead of just writing a policy and procedure and putting it on the shelf, we built a program and an infrastructure around that. So we allowed people and encouraged people to use in our bathrooms instead of on the street. And what we were able to set up was similar to the pictures that we saw, but imagine this in a bathroom, a steel table and a chair and a mirror, so that people didn't have to use on unhygienic
I'm gonna pull up a picture.
place. We're finding a picture of our bathroom to show you.
Is it okay if I share a screen again?
Yes.
Do we still have the power? Present slide. Hold on.
There it is.
From current slide.
So
Yep.
we
Uh-oh.
running this program, we did not believe that people should have to use sitting on a toilet or sitting on the ground in a bathroom. And that was not going to promote any kind of hygienic practice among folks. So setting up a sterile place for people to do that within a bathroom gave us the legal protection to be able to run an unsanctioned program. So in some ways, unsanctioned is not actually correct. It was sanctioned in a certain way. But building an infrastructure and a program around it was really unique to us. We were checking on people every 3 minutes by knocking on the door. And if we didn't get a response, we were going in to intervene.
Do you want to talk about this scene?
Yeah.
Do you remember that day?
So the picture with the oxygen tank and supplies on the ground was a day where we had 9 back-to-back overdoses, 9 or 11?
11
11 back-to-back overdoses
in an hour and a half.
in an hour and a half with 2 heart attacks.
2 heart attacks.
Everybody survived because of the level of skill that our staff were trained at to intervene in complex overdose response. And because they were able to use on site in the bathrooms of our program.
So you can see just that scene of absolute carnage, the aftermath. But someone had put borax in the drug supply. You know, this is a more controversial aspect of our work, but we work with, I'm going to stop sharing here if that's okay. We'll come back to you. We have something called the Canary Network and the Batch Alert system, where we are doing quite a bit of drug testing at our sites. Initially, it was just for fentanyl because that was what we were really worried about. We're expanding that, and we can talk about that in a few minutes. But at its height, we were working with 9 drug dealers in Washington Heights who would bring us their product before they packaged it up and put it on the street. So they knew if there was fentanyl in it, and so that we knew there was fentanyl in it. That allowed us to prepare for what was coming during the day. It was hard to build those trusting relationships with the drug dealers in Washington Heights. I'm not sure if you can tell, but Pia and I are both white women. And we work in predominantly Black and Brown communities, Puerto Rican and Dominican in Washington Heights, African American, Puerto Rican, Dominican, and Afro-Caribbean in Harlem. But we did it. And the unsanctioned program, or the loosely sanctioned program, as Pia said, saved well over 1,000 lives during its 6 years of operation. And we were able to use some of these innovative strategies to really compel the health department to back us as the provider to open these sites. We were good at making the work speak to people who didn't want to hear about the work. We made it digestible and understandable to some of the folks that were really critical or didn't understand what we were trying to do.
I just want to talk a little bit about the experience of shifting from the bathroom model to our sanctioned model as a provider. Kaylin, as she said, has launched and run consumption programs in Canada for many, many years. I was only familiar with running consumption within a bathroom. So removing the wall was a big deal as a provider. And what struck me the most was how seen and how vulnerable people felt to no longer be hiding. We know that these are behaviors that people have to hide, that is very ritualized as well, and is very, very private. When we opened our consumption programs and no longer had people consuming in bathrooms, we immediately had a lot of participants walk in, sit down in a booth and just break down crying. And for about 45 minutes of their visit, they were crying and being held by a staff person. And what we've seen over time is that when people feel seen in that way and supported in something that they're so ashamed of, they're able to look at themselves in a different way. And we're starting to see people who we've worked with for many, 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 many years, who have tried treatment many, 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 many times, now starting to stabilize their use, now starting to maybe not inject and sniff instead, which is a far safer route of admission. So there is even though we don't have long-term data, I see a really deep connection to people exiting use and changing their use just in the short time that we've been running.
I want to piggyback on that because she's so right. And this is such an important point. It's the least interesting thing that happens in the drug consumption room is the actual drug consumption itself. It's incredible and transformative what can happen when you actually allow someone to do what they need to do in a dignified way. So we have, our sites are polysubstance sites, meaning you can use any substance you want. They're polymodality sites, meaning you can use that substance via any mode of administration you want. Yes, you can smoke, snort, sniff, swallow, or otherwise ingest your drugs of choice. There are no time limits in our site because time limits aren't safe. Drug use, as Pia mentioned, is very personal and very ritualistic. I don't want to be yes to boofing. I don't want to be timed when I go have a shower in the morning or go do what I have to do. It's the same with drug use. Drug use also, timed drug use is risky because we're rushing. We're not thinking about dosing. We're not using proper hygiene practices. So we have a captive audience. Anxiety is low because the person is not going to be arrested. They're not being judged. They're not being rushed. They know they're not going to die because we're there supporting them. They're relaxed. They're consuming the substance the way they want to consume it to create the feeling they're trying to create. Lots of people use drugs for lots of different reasons. And then they're open to all of this beautiful work that can happen. So we have social workers and we have nurses and doctors who come into the overdose prevention centers and do sessions booth side with people while they're using. What a great place to do a mental health session, right? To help people process shame and what drives their use and addressing their riskier practices. Pia also said something that I want to emphasize. 100%, I feel comfortable saying that 100% of the overdose prevention center participants have tried detoxification, treatment, and medication assisted therapy for substance use disorder many, many times. Every single one of them, many, many times. What's so critical is that these sites are one step on the path to sobriety, but without this step, many people don't make it. Abstinence and harm reduction are not enemies. We often say that they're in a committed but slightly dysfunctional marriage. They need each other. The abstinence community does not agree when we say this, but we say it every now and then because we like to just be a bit of a pain in the ass. Abstinence fails every single time until the one time it doesn't. That's where a harm reduction program is absolutely critical. We are the net. We are the net that catches people who have burnt every bridge, been kicked out of every program, have returned to use a gazillion times, whose families don't want to talk to them anymore. We are the net. Without us, there's nothing. And part of our ideology and our resistance is really what is preventing the scaling up, the meaningful scaling up of harm reduction in all its different forms across the US. I'm very lucky. I worked in Canada for a number of years and got to run some really, really beautiful and innovative programs. Harm reduction is only starting to exist in the US. It hasn't existed here, even though we say it does, and everybody says they practice harm reduction, because it's inherently illegal to practice harm reduction here. So how can it exist? But it's finding a way, and it's finding a seat at the table in partnership with abstinence-based programs and in partnership with treatment and recovery and prevention in a way that is really going to yield positive results and start getting that bell curve back down. Safer consumption is also infinitely scalable. It doesn't just look like R2 sites, fixed sites. There are safer consumption sites co-located with detox and treatment programs. Co-located in the same space, run by the same provider. So you're in the life, you're grinding, you're in the safe consumption site, you're like, I can't do it anymore. I want to go to treatment. Wonderful, it's right upstairs. No referral out, no waiting for months and months. It's directly upstairs. Many people are probably like, that is crazy to co-locate abstinence-based programming and long-term treatment with a consumption site. Absolutely not. It makes perfect sense. The window is like this. Take it. Co-location makes sense. I've seen safe consumption sites operate in hospitals, co-located in hospitals. Excellent solution for people who use drugs who need long-term healthcare, hospital stays, for infections, cancer treatment, whatever it is. Co-located in housing. We know that the vast majority of overdose fatalities happen when people are alone behind a locked door, fearing the consequences of being discovered using. Safe consumption in a housing setting is very, very effective. There's not one way that this can look. Okay, I'm ranting now. You guys got to stop me. What other questions are there here?
Is there a difference between harm reduction and safe consumption sites?
Yes, harm reduction is a broad umbrella term. So it is a way in which we engage with people. Often harm reduction gets reduced to meaning giving out of safe supplies. I really disagree with that. I believe that harm reduction is a framework and a paradigm through which you work with people. It's about seeing people and meeting them in their use wherever they are in their use. It's also a framework to work with people who are selling sex and trading their body for drugs or other things. Safe consumption is a small option for harm reduction programs to practice the harm reduction modality.
Okay, I appreciate everything you ladies are doing. Don't get me wrong. But we are very fortunate. Everyone here does not live downtown or in a ghetto, right? We don't. We're very, very fortunate. We live in the suburbs. We got nice yards, nice homes, so on and so forth. Now, there are some people who can't afford what we have. And consequently, they're forced to live downtown or in a ghetto, but they're not doing drugs. They're living their life. They're going to work. They're raising their kids. They're doing their thing. Yet, right down the street from them, you have this facility that says, yeah, go ahead. You can use drugs here. To me, that's just wrong. You can't do it in my house. You can go down, wait. You can go down 2 or 3, 4 doors and you can use it there. I'm sorry, that doesn't make any sense to me. That truly doesn't. And what we need to do, and I've thought about this. My son is an addict. He's been an addict for 10 years. And someone asked me, what would you do, Neil, if Eric died? If he had the opportunity to go to a harm reduction or a safe consumption site and he died. He was there. They tried to save him and he died. Okay. Yeah, it would tear me up. But I don't want to be living next door to that. And the people who are working their butts off, going to school, providing a decent wage for their families, I don't think they want to be living next door to that either. Would you want it next door to your house? I know I don't want it next door to mine.
Well, shit, man, all my neighbors died. One of them overdosed. The other one committed suicide a few years after that. I wish there was a safer consumption site next to my house, and maybe those two guys would be alive right now.
I understand that. I don't want it next to my house. I don't.
It's already next to your house.
Oh, I agree. It's in my
everywhere.
neighborhood. Oh, it's in my
everywhere. You
neighborhood.
said your son's an addict yourself. It's in your house.
Oh, it's in my
everywhere.
neighborhood. I'm well
It
aware.
doesn't matter where you're at.
But the safe part is not.
No matter how much money you have, either whether you have a backyard or not, if it's downtown.
I can answer, Neil. I don't know if this is going to be helpful or if this is going to add gasoline, but let me. So in Harlem, with the unsanctioned program, it operated for 6 years and no one knew it was there. We were quietly doing this work with people who use drugs who really needed care, and the rest of the community didn't know. It was very, very quiet. If a consumption site is run properly and worth its salt, it integrates beautifully into the tapestry of the neighborhood. It's a medical service. It's just like a doctor's office. It doesn't have to feel that way. And I didn't mention this, but open invitation to all of you to come and see our sites and to meet our staff and to see how it works and to spend some time with us and meet the people who use our sites. But first off, a consumption site is not just going to pop up where it's not needed. It's not how it works. A consumption site would pop up. Hopefully, it would be thoughtfully planned, executed really well, competently run. But remember what I said earlier about, again, any provider worth its salt is going to open a consumption site that takes care of the needs of the people who rely on the site and of those in the community where the site is located. The sites have to meet both groups' needs or it's not going to work. And our sites do. We didn't open our consumption site without scaling up our outward facing programming to do community engagement, syringe litter cleanup, all kinds of other community work. They have to happen in tandem because we have a responsibility to both stakeholders. What else did I want to tell you? Oh, I have always lived, I believe that this is really important. I don't get to come on calls like this, neither does Pia, and tell you all this stuff about safe consumption sites if I'm not willing to walk the walk. And my entire career, I have lived in the neighborhoods where my programs have run. I live in Washington Heights where the consumption site is, so does Pia. I have a young daughter who I am raising in this neighborhood. She comes to work with me. She's been in the sites. She knows the participants. It's something I really believe in, and I believe that it is making our community healthier. I believe we are in devastating times. And devastating times and extreme times call for extreme measures. I don't even think this is extreme measures. I think this is good public health policy. But if you're not quite ready to be in that camp, then at least come into the camp of let's try this now. Well, we are losing hundreds of thousands of people, 1 million people, and your son could benefit from some of these programs to allow him the opportunity to recover. That's what they do. Our role is to keep people alive and to stabilize them. Stabilization and safety. I can hand a whole person to a treatment provider. I can't do that if they don't live.
Right.
Okay, I'm just going to interject here. We don't want people talking between themselves because this is a very controversial subject and easily we could start arguing, okay, which isn't productive for anybody. People start talking at the same time. So I did mute the parties who were going back and forth. So I apologize for that. But I did want people to put the questions in the chat if they could. I do see that Melissa Dobb has a question. that she wants to ask. I'm going to go ahead and ask her to ask her question. And then Neil, I see, wants to speak again, but we're going to hear from Melissa first. Go ahead, Melissa.
Thank you so much. So I am the Wayne County Commissioner for Plymouth and Canton, and I definitely support harm reduction efforts. I'm just wondering, so, you know, we've had a little bit of discussion on the legality of these centers. And I'm assuming, I'm pretty sure these are not legal in the state of Michigan. I don't know if you can confirm that for me, since they're not legal federally.
Yeah, there's no law that says it's okay to do this. I mean, put it that way.
Okay. I don't know if anyone has any information on whether we can make this legal in a county level, or is there anything that we can do in Wayne County to make this happen? Or I know in New York, you said you kind of had, oh, okay. I was going to say in New York, you kind of had like some agreements between parties that would maybe shut that down. But beyond that, is there anything else that we can do?
Yes, there is. I'm going to point to COVID. COVID really showed us the path. So when COVID ripped the nation apart and necessitated overnight standing up and mobilizing of resources to address a federal crisis, it happened because there was political will to do so. All kinds of laws were changed in every area of healthcare. As relates to people who use drugs, the restrictions on methadone dispensing, which is a narcotic, right? A controlled substance. It's and tightly controlled. All of that went out the window. Suddenly, so many things we've been fighting for years to reform literally happened overnight. What we were proposing in New York State, we didn't end up having to go this way, but what we were proposing was an enactment of an emergency services proclamation, an emergency proclamation around a public healthcare crisis. Your state government and your local government can do that. There has to be political will to do it. And people are going to say, oh yeah, I don't know we can't do it. Who's going to write that? Who's going to stick their neck out? We got to look back to COVID. Every state, every municipality did it. Essentially, you got to swap out COVID-19 and put in safer consumption. It's the framework, the mobilization and the resource framework has been developed. Mm-hmm. And I don't mean to be glib by saying that COVID and the overdose crisis are interchangeable, but I think the thought exercise, I think, is a good one. All of the infrastructure around an emergency diversion of funds, creating those funding pathways, reforming law and policy, that all happened with COVID because there was political will to do it.
Mm-hmm. Okay, got it. Thank you.
Mm-hmm.
Okay, we have a couple more questions. Neil has his hand up. He has had it up. Also, there's a question from CleanWorks, but I just want to emphasize these should be questions and not statements. If there's a question that you want our speakers to answer, I'll go ahead with Neil. I'll ask you to be brief, Neil, okay? And you're just going to state a question and then we're going to move on. And I don't want to hear anybody responding other than our speakers. Oops, go ahead, unmute. I'm sorry.
I like to look at, before I make a decision, I like to look at both sides of the story. And there was a forum that I wanted to attend. It was over in Macomb County, and Aaron put it on, and I wanted to go and I missed it, and I was really upset with myself. But in looking at both sides of this, there's harm reduction in Portland, there's harm reduction in San Francisco. And if you, depending on what newspaper and what political leaning you have, You're either for it or against it. And there's some really bad things that are happening in Portland and San Francisco. It's not clean. It's not safe. Murders are on the increase. Crime is going up. I understand what you're doing and bless your hearts. It's something needs to be done, and what it is, I think we should just get more border patrol. I don't know, stop it all. We won't be able to stop, but I lived through the methadone clinics. I was back in the 60s and it didn't work. And I don't think this is going to work either. It will help, but it's not going to eliminate it. I'm done. I won't ask. I don't have any more questions.
Okay, I don't know if that requires a response. Do you have a response for that?
I agree, Neil. But it's a little bit more complicated that. I know Pia wants to jump in, I can tell from her face. But one thing that safe consumption often is stymied with is this conflation of what we're aiming to do with the rest of the problems in society. Safe consumption sites are not going to drive the murder rate down. They're not going to deal with gun violence. That's not what they do. They are a public health service really meant to reach a very vulnerable population who is at immediate risk of losing their life, and getting them into care if we can. This is something we battle with all the time. There's a gun violence issue in Harlem. I'm sure you've seen the news coming out of New York. Wow, are we having a hard summer after 2.5 years of being on lockdown? But our sites are not going to immediately redress those issues. We have to make sure that people understand that we're taking care of our small part of the problem the best way that we can. But massive reform of the housing system, gun laws, that all also has to happen, Neil. So yeah, in large part, I agree with you.
I want to just say that Portland and San Francisco do not have accessible safe consumption programs running. There is one in San Francisco. Access is very, very limited. So the issues that we're all seeing of syringe litter, paraphernalia, people using in the open, people dying behind closed doors, those are the issues that we're addressing with our program. We don't want people injecting or using drugs in public. We want that behind a closed door with somebody who is trained to respond in the event of an emergency. And what we know is that nobody dies in a program that's set up like that. So we're not going to get rid of drug use. Drug use is going to keep happening. Whether we give people an opportunity to live through it or not is what we're trying to address.
Okay, thank you. That was great. Now we have another question from Rick M. I'm going to ask him to unmute, and please ask a question and be brief, please.
Well, hello, everyone. I'm Rick M. Griff, recovering addict. To Kayla and Pia, thank you very much for coming out and giving us your views, even though not everybody, as myself, may, I should say it, like them, because we all got our own opinions, right? But as from an addict's point of view, and one who has already lost a son and 2 nephews to the overdosing, I don't feel myself that facilities such as yours, where they allow to come in and whether shoot up or however use under a controlled, situation, is good. Now hear me out though, is that, now I've been with the fan group for quite a while, and the whole thing is like when they came out with the hopes and not handcuffs, I seen that starting to help. There's always something, but in, like, say, our fellowship, we also have what we call public relations, whatever. And in that place, couldn't you put more emphasis on something along, like, because you mentioned something about using in a hospital and then also going upstairs or wherever to find the help. So couldn't you put more effort into something along the help of finding somewhere for these people? Because yeah, they're scared when they're using and everything else. So they don't know where to go most of the time. So instead of saying, here, come on and you can shoot in here and we'll take care of you or whatever, how about if we take you and find you the help you need. And most of them will probably say, yeah, okay, because I do want to kick the habit. It's just that I don't know how to. And that I know personally, because like I said, I was out there 47 years, so I know what it's like. But once, it's the pain. Once they're over the pain, the pain is the motivator, is what it is. So I'm just saying, couldn't you guys more or less manipulate, or whatever the word is put your energy more into finding that people's help?
We do.
regardless?
We do. This is crazy. This is something that I didn't expect to work as well as it is. I'm going to tell you something really depressing, two really depressing things, and then hopefully something a little more positive. One, if you are on Medicaid in New York State and you want to go to treatment, and you go through the program and you're released very likely into the conditions that kind of fueled your addiction in the first place. You have no job, your family won't talk to you, your house somewhere totally shitty, like your life is pretty terrible, and you return to use and you want to go to treatment again and try again, Medicaid won't pay for it.
Right.
That's one, right? So that's a system failing. That's not our fault.
No,
And
I didn't
what
mean
is
that.
what is so heartbreaking is when that happens, especially in the Washington Heights program, to these very young people. I'm thinking of you know who I'm talking about, 21 years old. He's like, I can't. He overdosed with us. I think he's overdosed with us probably 20 times. We have kept this kid alive 20 times, Rick. And he's alive still at 21. And he said, I can't. Tears sobbing down his face, snot all over the place. And he said, get me into treatment. And Medicaid said, we won't take him. He can come again in 6 months. To a 21-year-old kid who says, get me out of this life. That's one. You better pray there's a consumption site around to keep that baby alive until the system will take him back to get him sober. That's where you want us, Rick. The other really depressing thing I'll tell you, if someone is dependent on a stimulant, methamphetamine, oh God, K2, crack, cocaine, whatever, and it's deleterious to their body, they're psychotic, they're doing survival sex work, God knows what's happening to them, and they want to go to treatment, in 2022 in New York State, somebody on Pia's team has to go around the corner to the old New York bodega and get a 6-pack of beer and get that person to chug 2 or 3 beers before we can get them into a treatment program. Do you know why? Because in New York State, detoxing from stimulants is considered to be a psychological process where you are not at risk of losing your life. You can't die from a detox from a stimulant because it's a psychological dependence. Whereas if you're detoxing from alcohol, opiates, or benzodiazepines, that you need a chemically or a medically supervised detox. So in New York State, there's this classification of which drugs deserve treatment and which drugs don't. What do we know about drug use in America? It's all polysubstance. People are on meth, they're on cocaine, they're on crack, they're on this, they're on research chemicals, MDMA, mushrooms, acid, heroin, cocaine, fentanyl, they're on everything.
Been there, done that.
Right? Exactly. But you cannot access treatment unless you are using, thank you very much, Aaron, totally right. Unless you are using a benzo, alcohol, or an opiate.
Right.
Again, you better hope there's a consumption site in your neighborhood if you happen to be a stimulant user in all of the chaos and pain that your life is, if those are the substances you're dependent on.
I can understand, I love what you're saying.
But remember, Rick, I was going to tell you a good thing. Remember, I said 2 depressing things and 1 good thing.
Yeah.
So let me tell you the good thing. The treatment providers that we work with, because we work very closely with treatment providers, because you better believe me, we are very good at capitalizing on that moment where someone says, I'm done. We are right there. We pick you up and we get you where you need to go. What I didn't expect was that the treatment providers were going to change the way they were working. I didn't think they'd want to go anywhere near the consumption sites. That's not what they do. Yeah. We'll meet them outside, bring the person outside. The treatment providers are working with people in the room.
Right.
That is one of the most beautiful unintended consequences of opening the consumption sites. The treatment providers said to us, you're changing the way you're working with people who use drugs. We have to change too. They are in the sites working with people around treatment readiness while they're using. And I just feel like I just want to kind of do a mic drop right there.
But you know,
Because-
too, though, is that the one thing I'm just saying is anybody and everybody there can sit there and say, this guy's out of whack, you know, and I don't really care. But what I'm getting at is that, to me, it seems like a bit of enabling to a certain point, and that I don't believe in is what I'm getting at. And yeah, the system is, I believe, at fault because there is the stigma around a drug user, and we can't help that. And drugs have been around for longer than what they say is the world's largest, profession. It's been around as long as that has been. But you know what? We got to put a stop to it. And that to me even includes enabling. And I am old school. You know what I'm saying?
You're not
I
really
just
that
don't
old school,
believe in
Rick.
that. Huh?
You want to talk about the enabling thing?
Yeah.
Yeah, I think that people, as you know, Rick, you were probably using drugs. I don't want to assume. Let me talk about somebody else. People are using drugs and stopping on their own terms.
Right.
And it's only working when they're doing that on their own terms, right? That's why people try and fail and fail and fail. And the big, again, going back to the harm reduction as a modality,
You good for a
we're
second?
just gonna have the baby
Here comes
get
the
a little
baby.
bit of love.
Here she comes, everybody.
The
We
thing
got a
about-
newcomer here.
The thing about harm reduction as a modality is the belief that when you're ready, we're going to take you, but it's going to be on your terms, not mine.
Right.
And that's what the program enables. It enables people to get to their own place on their own time. I want to go back to what I was saying and what I was so struck with when we opened these programs was how emotional people were just by being seen, and how that changed the way they looked at themselves and the way they looked at their use. People want to change their use when they feel like they have a support system and they feel seen and they're not hiding from themselves, right? Drug use is a way to hide from your own pain.
Right.
And facing that pain is terrifying.
Oh, hell yeah.
When you have a support system, when you have people that believe in you, that are cheering you on, that are making sure that you're not dying, you're not transmitting diseases, you're not harming yourself, then you're going to invest in yourself.
Can I just say one more thing and then I'll clear off? It's just that I really appreciate what you guys have brought to the table today, regardless if I maybe disagree in whatever in the back line, things, it doesn't matter. I just have my opinion, but I'm glad that you guys are doing something at least, because this whole thing of life, drugs in life is a process. And who knows, it can take another few hundred years before something gets a handle on it. But at least you guys are trying something, and I love it regardless whether I like it or not, because I can go with acceptance. Thank you very much.
Rick.
Thank you. Okay, I'm going to ask Teresa, and again, Teresa, you need to ask a question and be brief, okay?
Okay, so this program isn't offered in Michigan is what I'm hearing. And I wanted to ask, before I was in the program that I'm in, and thankfully and gratefully I am, thank you, Judge Mack. When a person that I met, when I was out there, I met 12 girls that were on the street. Most of them all younger than 20. 8 of them I know before I started the program with the court were dead. So I wanted, and then the girls that I knew that were left, they wanted to get clean, and I would bring them to my house. There isn't, but that wasn't useful either. So the people that are here that I know, is there a way for me to refer them to you, even though they're in Michigan, so that they're still alive? I mean, they cry, they want to get clean, and I want to give them that support, especially since I wanted to, but I needed the help of the court system just because they were so supportive and gave me everything that you kind of are giving to other people.
Teresa, can I just chime in? You can contact FAN. FAN has peer support people that they can, you're frozen. I don't know if you're hearing me. But there are resources available. So just if you need resources for someone, reach out to the treatment team at the 29th District Court.
The only-
Okay,
The only thing that Pia and I can offer there, and I really appreciate the Teresa, or the question, Teresa. One thing we've not been really great about in the States is helping each other develop programs. And I just want you to know that Pia and myself and everyone else at our team is totally available to get on the phone or get on a Zoom and start trying to think through how to build some of this and get in place some of what you need in place, especially at a policy level, to start moving some of this forward. Someone did it for us. You know, we all learned what we know from someone who came before us, and we see it very much as our duty to share that. So if that's helpful, Teresa, or anyone else, please know that we're available for that.
thank you. I'm gonna call on Lisa next, and then I'll get to CleanWorks. I apologize. It's just taking a little more time. Go ahead, Lisa.
Okay, thanks. Your program it's amazing. I'm so excited that this has started finally in the US, and hopefully we can get it moving into other states as soon as possible. I lost my son 2 years ago to heroin overdose. He had been using for probably 10 years. I guess I don't really have a question. I guess I'm saying, I agree that had he been able to go somewhere and been seen for his beautiful soul and the human that he was and what he had to offer and give, and had he felt dignity still, regardless of the fact that he's using, that he could not control this, but he hated it. He hated it with a passion. I believe that we could save so many people. He wanted to get better, but there was no way forward that was really clear cut. So many obstacles. Insurance was a big one. And then he had a criminal record that was also something to deal with, very difficult when you're using and when you have such low self-esteem. My husband and I, we thought we're doing everything we could. We thought we understood, but we didn't. You know, I mean, even after so many years of dealing with it and participating with FAN for years and trying to understand, you know, going to meetings ourselves, it's just so complex. There's such multifaceted. I believe that we just need to be open to whatever is available. I think that this is a real big push towards a very positive, a very necessary approach. And if you're working with the communities, helping them to understand and see this as a safe thing, and the people that are coming there are respectful as much as they can be, because they're being respected, they're being seen in a community, they're not being shut away. I just think there's so much positive about this. I'm so excited and hopeful.
Lisa,
Thanks.
I want to tell you, I want to thank you so much for sharing that. And I see you, CleanWorks. We had participants. You're one of those moms that we dream about. Not every parent is able to get to this place when their child is using. You know, we have had folks, particularly our young folks, come to the program. I'm thinking of Chris, and he would take a picture of himself in the consumption site and send it to his parents so his parents knew he was safe. And you know, what a tough journey for a family to be on, for mom and dad to get that photo and for him to take it, but that was the way they were making it through. You talked a little bit about a criminal record. We hire people with criminal records. We don't believe in ban the box. This is, somebody asked, like, what is harm reduction? Harm reduction is hiring people with criminal records and giving them salaried decision-making jobs, inviting them back into society for real. And you know, it sounds like we would have loved to have hired your son to work in one of our sites. But that's a means of engagement, that witnessing, that seeing people and saying, you matter. Your drug use is not the only thing about you. Just because you use drugs doesn't mean you don't have anything to offer. And we want what you're selling. And I think, I don't know what the number is right now, but I think it's like 30 to 40% of our staff either are actively using and working on it, despite their criminal histories or have very recent lived experience with use. And then the Washington Heights program is almost all consumer led. It's a huge important piece of this. So thank you for sharing that.
Okay, CleanWorks, you've had your hand up for a long time. I apologize. Go ahead and unmute and ask your question or make
And
your
I
statement.
apologize too, but I've been waiting so long, I forgot what my question was. Did anybody else here have any questions?
Boom.
I have a long statement I'd like to make something.
I know what one of the questions was.
Yeah, I bet you could guess what it was. It's in the chat 3 times. Go
How do
ahead.
we do overdose response and how
Yeah, you
Yeah.
mentioned microdosing.
Yeah.
and how do we use oxygen?
Okay, so I want to talk about oxygen first because I think oxygen is more important than naloxone. So forget about your naloxone for a second. Opioid overdoses, as you guys probably know, is respiratory depression. It's all about the lungs. If you keep the lungs working, then you're not going to have the heart shut down. You're not going to have the brain shut down. You need oxygen, 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 oxygen. Even if you don't have naloxone, you can keep somebody alive from an opiate overdose with oxygen alone, breathing for a person, or better yet, having an oxygen tank. But we know everybody doesn't have an oxygen tank, right? Getting oxygen in your programs is one of the most important things you can do. It gives your team and your participants a way to keep their brain cells firing. What we know from long-term use and opiate use is that people suffer significant brain damage from living through overdoses without getting enough oxygen. So our overdose intervention is really, really grounded in that being the most important tool. Sometimes, because we're catching an overdose so early, the way that we're ensuring that a person is continuing to breathe is by stimulating them. Agitation. So painful agitation. Of the sternum, of the traps, rubbing somebody's back, really grinding into those muscles and talking to them and getting them to take deep breaths. Walking them around, putting one person between 2 arms and actually stimulating cardiac behavior so that the body breathes. At the most severe level, we are putting an oral airway in or a nasal airway in and breathing for a person with a bag, like what you see on TV, right? These airways are not hard to insert. They're not fully intubating a person. They're basically just opening up the airway so that you are ensuring that oxygen is getting into the lungs and not into the belly or just blowing on their face, which isn't going to do anything. The way we use naloxone is very, very specific. We're only using it in instances where agitation and oxygen are not showing improvement, and we're using very, very small doses. So this is where the microdoses come in. We're using the injectable form of naloxone preloaded into syringes so that we can taper the dose. We don't just give an entire 0.4 milligram, which is what the intramuscular naloxone is, in one hit. We're doing small doses and seeing how the person responds. We might be giving 3, 4 full preloaded injections 4 to 5 minutes apart over a 15 or 20-minute intervention. These are very, very long interventions that are requiring continuous oxygen throughout the intervention. Did I forget?
You just only forgot 2 things, but that was great. Okay, 2 things to add. Is overdose response in an overdose prevention center is all around preventing the loss of consciousness. The mirrors are essential for that. The mirrors allow the participant themselves to have control over their environment. They can see behind them. That's not a luxury for survival drug use in the street, right? Am I going to get raped? Am I going to get robbed? Am I going to get arrested? So the mirrors really help quell anxiety and make them feel that they're in control. It also allows our staff to see the trigger point. We call it the trigger point. So yes, I'm prepping my shot. Yes, I'm tying off. Yes, I'm cleaning the location. Yes, I've registered. Now I've administered. So it allows us to see the second the substance hits the system and decide what we're going to do in the 10 seconds after that. So the intervention is immediate. What's so sad about that 108,000 fatalities last year is what we all know about an overdose is somebody was there with a very little bit of training, they wouldn't have resulted in a fatality. OPCs take that even further, and they're there the second the medical emergency starts. So often we're able to get in there and prevent the loss of consciousness in the first place, even with a very heavy fentanyl involved overdose. The other thing that I would mention is overdose response in this setting, or our philosophy of overdose response, is a little bit unique in that it's all about symptom management, neurological, cardiovascular, and respiratory symptom management. We are not necessarily looking for 100% alertness. We're looking for normal respiration, solid cardiac activity, and no adverse neurological function. So the person can still be incredibly under the influence, but not medically at risk. So this is going to be probably a little pokey for some of the folks in this forum, but that is patient-centered care for people who use drugs. So we don't know, and we always what people have had to do to get that particular dose. We are not going to ruin it. And we are not going to cause precipitated withdrawal, because that actually increases risk for the person. It doesn't actually decrease risk for the person. And if we trigger precipitated withdrawal, we're at risk of losing the person back into the community, which is not achieving our ultimate aim of safety for them and safety for the community. So a response, quote unquote, can sometimes be several hours long. That's fine. But the person is not in pain, the person is not medically in danger, and all three systems are functioning optimally under our observation and care without ever having to call the ambulance.
I've seen a question come up on the chat a bunch, and this plays a role in overdose response. The question has been, how many times can a person use the site? That's unlimited. People can come back as many times as they want. What we do is we kind of act like a bar, and our staff are kind of like bartenders, and we're gauging whether it's time to be like, hey man, you really need to just pause, take a break, let's give you some food, let's connect you to our other programs, and then you can come back. Or if that kind of conversation is going to push somebody away and outside into the street, like where is the risk there? Is it on them? And how can we work through this? So while a person can come in as many times as they want, we're also there to coach and to support people in making decisions about their own bodies.
Does that answer your question, CleanWorks?
Yeah, I kind of want to piggyback on that. You guys have like a time where you don't have places available or booths available for people? And what do you do in that situation?
Like we run out of books.
Yeah, so we have an 85-page policy and procedure manual, and a big chunk of it is around managing flow to the space. So that's a very important concept, especially when you are really hell-bent and determined to not have time limits. So there are certain things that are allowed in the Overdose Prevention Center, and necessarily there are certain activities that aren't, but they're what you would expect. We don't want you to have a full meal at the booth. We don't want you to do your makeup at the booth. We don't want you to unpack your suitcase at the booth. The booth is for consumption, and a visit to our site is by dose as determined by the participant. And that's a really key, unique feature of our site. We ask that you be prescriptive when you come. And what that means is you tell us what your dose is before you sit down. So, hey, my name is Kaylin. I'm going to be doing a speedball. I think I'm going to need 4 syringes, and I'd like to visit the smoking room. Great. Now our RPICs, our responsible people in charge, now they have an idea. They can ballpark how much time you're going to need. But once you are done your dose, you are asked to go and go to one of our other program spaces so that we can get somebody else in. A well-designed site should take into consideration the number of people and the modes of administration and the preferred drugs of choice of the area where it's going to be located. So our Harlem site is bigger and has the dedicated smoking room, communal smoking room, because we have a higher volume of smokers. The Washington Heights site is all those young injectors, and thus the site reflects their needs. We have 2 smoking vestibules in the Heights, but it's mostly injectors. So you, from a design perspective and kind of a needs analysis perspective, you've got to look at that when you're starting to think through how many booths, what do I need for smokers? Do I have sniffers? Like, what am I going to need to make sure that as much as possible, we don't have wait times? Because I know the point you're getting at, that's when you lose people. And we can't have that. You also need very skilled staff who can manage the flow in the site and make sure that it's humming. And that's really around boundary setting, expectations, right? You're here we've got other spaces where you can do all that stuff, like, let's move it along. Somebody's behind you, you can come back, all that kind of messaging.
It's also about relationships with, I'm sure CleanWorks, you guys know, everything that we do is rooted in the relationship that we have with the person. And that's really key in being able to maneuver difficult and challenging circumstances. But really, these programs give you an opportunity to deepen the level of care that you're providing.
I have a question for the woman in charge here. What's your name, ma'am? I'm sorry. The administrator.
Kaylin?
You talk,
No, not you, the one from Michigan. The woman
Yes.
from Michigan.
are you talking about Lauren Rousseau or myself,
You.
Judge Laura Mack?
The one that's speaking right now.
Okay,
Is that the judge? I'm sorry. I can't.
yes.
Hi, I'm just curious to know, like, what this meeting, like, how is this gonna, like, are we leaning towards safer consumption sites? Are we just trying to figure out what's going on? Like, you know, by talking to these guys, like, what are you guys, like, trying to gear towards that? And is that the whole purpose of this? Like, how, like, what, how soon?
I'm going to let Lauren Rousseau answer that question. She's a law professor. She was the president of our chapter for many years. And it was her idea to bring this to us. And I'm going to ask her to speak on that.
Hi there.
Hi.
I'm Lauren Rousseau. So our fan chapter, you know, we kind of missed the introduction because Judge Mack ended up getting bounced off the call. We jumped right into the presentation. But fan chapters in Michigan have monthly public forums. So every month we present a speaker or we do different things, usually educational in nature. This is our regular monthly public forum. We're usually the first Monday of every month, but this time because of the holiday, we're the second Monday. So we have an interest in this type of, you know, and anything that's addiction, treatment, recovery related. And I mean, I at least became aware of the opening of these 2 overdose prevention centers and was super excited about learning more about it. You know, our fan chapter is increasing. It's sort of adopted a harm reduction program. Whether or not, you know, we would go in this direction, I can't say. I mean, this is just more learning at this point. But, you know, this is a new and kind of exciting development. Like I said earlier, it's a new frontier in harm reduction for the first sanctioned overdose prevention site. So we wanted to learn about it and we wanted to bring information to Michigan and to our audience about it. So that's kind of where it is at this point.
Awesome, thank you. I think that you guys are doing a great job. Like, I've learned a lot, like, even, and I'm a recovering poly-substance user. So I just kicked heroin, so, but I would definitely love to see safer consumption sites, just so, you know, just to keep myself healthier if I do relapse, or, you know, to see my friends not die. You know, I have a lot of friends and family. There's a lot of, you know, unnecessary death, and people, you know, people don't deserve to die because they have an addiction. You know, it's like they said, I think it's awesome that you have the counseling available. And, you know, I could see this becoming or helping people to reach a point of like solid recovery just by taking out the thrill of, the thrill of being in the streets, and, you know, which I've overdosed myself and I've saved people, and I don't want to have to do that for anybody. You know, I would rather leave that to professional. So
thank you for that.
Yeah, thank you.
There are some more questions in the chat. We are running out of time. But one of the questions was from Rick. He wanted to know if you have, how long to continue someone on oxygen. I'm going to ask the question for him because we want to move quickly through the rest of the questions.
Yeah, that depends, Rick. It's really until normal respiration can be maintained, which will support cardiac function. So sometimes it's 10, 15 minutes, sometimes it's 3 hours. It really depends case by case. And I'll just answer really quickly the finance question because I do think it's a good one. Our programs, by and large, are funded by the New York City and New York State Department of Health, but the overdose prevention centers are not. They could not come on as a funder because they are federally still illegal. So they are funded by private and foundation money and donations for now. However, we are going after the opioid settlement money hard. And New York State is working, and so is New York City Department of Health is working really hard to ensure we can use those funds to operate the overdose prevention sites. So hopefully, because that will make it easier for you. If we can figure out a funding pathway, that'll be take a big sort of operational challenge off of other jurisdictions' plates.
Kaylin, can I jump in and ask you a quick question? This is Lauren. I was just wondering about whether there is any discomfort or reluctance within the substance user community where your sites are located, like if there's fear, right, about coming out into the open in that way. I'm just sort of wondering about the proportion of people who actually use your sites versus the proportion of substance users in the vicinity. Is it just a small proportion? Are there a lot of people who are afraid to come into the overdose prevention sites? Just wondered.
So many things to say about that. Yeah. One, the older the drug user, the more difficulty they had using in the open. They were sort of like, there was deep shame and deep stigma. The young pups in Washington Heights were just sort of like, oh, this is great. I'm safe. You're here. You're watching. You're going to help. Good. The old codgers in Harlem were like, this is disrespectful. Like I should be hiding my use. Nobody should see that. It was, I don't mean to laugh, but it was honestly a little bit funny. You want me to what? You know, but they got used to it. So there was definitely that. There was real fear of poaching, warrant poaching from the NYPD. Obviously, everybody has seen the reputation of the NYPD has really taken a beating recently. So has law enforcement across the country. And that quickly fell away when it was very obvious. The NYPD, believe me, I've had trouble with cops in this work all my career. No one was more surprised by the cooperation and partnership of the NYPD than me. But they are not on our block. They are not poaching people. They are really been wonderful partners. So that fell away really quickly. What did I miss, Pia?
I just want to say that I think the ways in which we're working with people who are female identified and otherwise identified is really important. What we've seen with our syringe access data is that a majority of the people who come to we have scattered sites throughout the city where we're providing syringes and accepting returns are men. We see a lot of women who are in transactional relationships not coming and accessing services. The male identified person in the dynamic is often the person who is accessing care and accessing information and then bringing it back to another person. What safe consumption is about is bodily autonomy. And so being able to work with women and to give them the tools to make decisions about their own use on their own terms is allowing us to work with people who would otherwise not have access to that kind of care. And we're starting to see people come out of the woodwork a bit who have been getting syringes from us via another person and are now more confident to walk in because they know the care that they're getting is a little different than it was before.
Thank you.
Okay, are there any other, I did want to just let our audience know about some upcoming events we have. Do you think this is an appropriate time to do this? I guess we'll go ahead with this. This is what I tried
I
to do
do, yeah.
earlier, so I
Laura,
apologize.
Laura, I think there's some questions in the chat still that we haven't answered.
Okay, well, I do want to get to though our upcoming events, so why don't
Okay.
I do that really
Okay.
quick? And then we can get to the questions.
Sounds good.
Because we normally end by 8:30 at the latest, so we could run a little bit later, I guess. This is a very interesting presentation. So let me see if I can share my screen. Okay, do you see it? Can you see it?
Yep.
Okay, all right. Before, when I tried to do this, that's when everything disappeared. So, okay, we'll go through this really fast. I just want to mention we do have groups, and I can't go back for some reason. Let's see. Okay. As you know, as Lauren said, we do meet monthly, first Monday of every month. We're really proud of our Stronger Together group, which is a support group for family and friends of people who suffer from the disease of substance use disorder. We have a very, very robust Stronger Together group. We have more than one. We have one during the day, I think, and one in the evening. So let us know if you're interested in any information about that. We partner with New Hope Center for Grief Support in Northville for people who have lost someone to substance use disorder. Again, we can give you information regarding that if you're interested. We do have flyers for our Stronger Together group and also for the New Hope group regarding substance use loss. We do have an event coming up. August 31st is our Overdose Awareness Day event. It's going to be the same place as last year at the Heritage Park South Pavilions. Again, we will be sending out and posting these on our website, but just so that you can put it on your calendar if you're interested to honor those that we have lost to this disease. FAN offers peer and family recovery coaches free of charge. So this is an awesome, awesome program. They've received funding from the state to fund programs like this. So please, if you know of anybody who could use a peer support person or a family recovery coach, let us know, or just go to the website. In fact, I might be able to. I thought I could, it was embedded, but I can't. There's a website on the FAN. There's a page on the FAN website that talks about that. Sober living scholarship programs. People coming out of rehab often have no resources. FAN can help with that. So please, again, if you have anyone that you know that's leaving rehab that needs funds for sober living, let us know, or just go to the FAN website. Our next forum is Employment After Conviction, August 1st, in person back at the summit. So please join us. This should be a very interesting one. Obviously, employment is a big issue after conviction and while you're in recovery. And so there are tools that can help people navigate that. And we'll also be doing a Narcan training. So if you come at 6, we'll do the video and you can get a Narcan kit. So please, please come to our forum on August 1st. We're sponsoring a golf outing. Again, we did it last year. This is our second. Friday, September 16th at Fellows Creek Golf Club, same location as last year. It was a wonderful event last year. So if you know of anybody who golfs or anybody who just wants to come and have fun, let us know. There was our speakers. And again, I just want to emphasize again that we are here for you. We have resources. We care. We care deeply. I've been impacted by addiction. All of the people on our board have been impacted by addiction. And we really, truly care. And you are not alone. If you're a family member, if you're a person in addiction yourself, if you're in recovery, you are not alone. there are people that care and will help. Okay, that is what I wanted to convey. Are there any more questions? Let's see. I'm looking through the chat. Anybody have anything? I'm trying to see if there are any more questions.
Are you two in recovery?
The two speakers?
Yes.
Yeah, I was, when I was very, very young, I left home when I was 11 years old. And I was heavy into methamphetamine and cocaine use for many years. I didn't finish junior high, but I did manage to get my life together. And obviously I'm still here today. But yeah, I have that experience.
Thank you. And thank you for sharing that. I think it's important to, to combat stigma by sharing our personal stories.
Agreed.
Alfred, did you have a question?
Marissa had this question. So before the BVM, OPA, and MPA is needed, are you using? Great question. And it's kind of the opposite. So going back to the idea of the question was, are we using the bag valve mask, oral and pharyngeal airways first, or are we using rebreather masks and oxygen first? Really depends. So going back to that symptom management, especially with fentanyl, and the onset of a pretty serious overdose can be immediate, or it can happen, it can progress slowly over time. So our primary effort is to prevent the loss of consciousness, as we mentioned. So that's going to be with agitation and a rebreather, just to keep oxygen flowing to the brain, to prevent the brain from shutting down. But in a really heavy fentanyl involved overdose, that step is sometimes completely jumped over. The loss of consciousness is almost immediate, in which case we'll jump straight to an oral or pharyngeal airway, especially if the jaw is clenched and we can't get an oral in because of fentanyl. So we'll go to a pharyngeal and a BVM, a bag valve mask, right away. Does that answer your question? Yes. Okay.
Well, me, I got another one. I got a different one.
Okay.
Okay. This one is during the incident you were talking about earlier, about responding to the chaotic event when many people were suffering at the same time. It occurred to me that if you hadn't done that, if you hadn't been there at that point and they hadn't been collected in that area, those incidents with that particular product would have taken place over a wide area, and then would have been even more of a burden to, I know probably, I don't know if emergency personnel came there, but that doesn't matter for what I'm trying to ask. So this actually is service to emergency personnel, because they know they can go to a safe area to collect the individual and move on with their evening's work or whatnot, or day's work.
Well, take that even further down the road. We are not calling them at all. All of the staff in our overdose prevention center, including the consumer-led model, they are all trained to respond at the same level as a registered nurse. So this is very advanced overdose response. We are really giving technical skills back to a paraprofessional staff base, with the express purpose of minimizing our reliance on emergency services. So 370 overdoses, only 5 ambulance calls, and those were all for factors not related to the overdose itself. We'd resolved the overdose. This was more related to underlying health complications or other unusual presentations we felt was outside of our skill set.
Wonderful. Thank you.
Welcome.
Kaylin and Pia, I just wanted to jump in and say thank you so much for this presentation today. You both were amazing. And I think that I at least feel like I learned more than I even expected to learn. So it was great. And I really appreciate you taking the time to speak at our forum tonight.
It's our absolute pleasure. Thank you so much for having us. We were both a little scared when we saw Fan in our inbox initially, but we're very, very grateful for this invitation and for this conversation.
And we're happy to continue the conversation in whatever way would be most helpful.
Thank you. Thank you so much.
All right.
This was a wonderful presentation. I think one of our best. So
Thank you.
Great. I'm glad you thought so. Okay.
good
Well,
luck in the
keep in
work that you're
touch.
doing.
Good luck over there. Thanks,
Yes.
everyone.
Thank you so
Bye.
much.
Goodbye.
Thank you so
Bye-bye.
much.
All right.
you
Well, thanks
talk about-
everyone for coming.
You talk about some knowledgeable people. Not once did I hear them say, I don't know, I'll have to get back to you on that. I think they answered everything so good and, to the max. So whoever picked these two people to speak, kudos to you. Thank you.
Yes, thank you, Lauren. It was her idea and she found them and brought them on board. So thank you so much.
Thank you, everyone. I thought it was great too. I'm really happy with how it went. We learned a lot, and now we'll see what we do with that knowledge going forward, right?
They were outstanding.
Mhm.
Yes, and we had a county commissioner here who was interested in this. So it was quite worthwhile. And thank you all for participating. I'm going to go ahead and I guess Alfred needs to end the meeting, but
Bye, everybody.
Bye.
bye.
Good night, John Boy.